amigas y amigos, gracias por acompañarnos hoy. Esta es una actividad del proyecto ECO en Uruguay, que estamos muy contentos de que todos nos hayan acompañado. Estamos trabajando incansablemente con el profesor Max Watson de Irlanda del Norte desde el día lunes. La verdad que nosotros estamos cansados y debe estar muy cansado, pero estamos tan contentos porque tenemos una fuente inagotable de inspiración, de humanismo y de sensibilidad con el profesor Max Watson, que es además la máxima autoridad en el tema de cuidados paliativos en Europa. Él nos está acompañando, dando charlas en el Hospital Británico, acá, mañana en la Academia de Medicina, y ayer de una charla maravillosa en el interior del país, en la ciudad de San José. Todo esto gracias a la asociación en el tema de cuidados paliativos entre el servicio del profesor Watson y el servicio de la doctora Gabriela Piris del Hospital Maciel y de todos sus compañeros que tienen ramas en varios lugares más del país y que son todo un ejemplo al decir del profesor Watson para todo el resto del mundo. Y como la mayoría de ustedes no sabe qué es el proyecto ECO, yo le voy a explicar en unos pocos minutos antes de darle la palabra al profesor para que dé su conferencia del día de hoy. Llamamos o decimos que el proyecto ECO es una iniciativa para democratizar la atención médica y fue creado, como ustedes ven en el primer slide, por el profesor Sanjeev Dora, a quien ven en esta foto, siempre está sonriente. Es un hombre que nació en la India, que vive hace más de 20 años en los Estados Unidos, en Albuquerque, de verdad en el estado de New México, uno de los estados más grandes y también más pobres del gran país del norte, y que estaba muy preocupado porque no podía dar abasto él en su asistencia a los pacientes con hepatitis C. Era el único gastroenterólogo en todo el estado que podía diagnosticar y tratar esta enfermedad y estaba realmente angustiado, hasta que ideó o se inspiró en realizar este método que es simple aparentemente, pero es la simpleza de las cosas o de las personas geniales. Él inventó este sistema que consiste en educar a los médicos y al personal de salud radicado en ciudades pequeñas del interior, en áreas rurales, en establecimientos penitenciarios, allí donde hubiera pacientes y donde hubiera personal de la salud. Él estaba obstinado, digamos, en educarlos y empezó a darle la educación pertinente para diagnosticar y tratar la hepatitis C y posteriormente le da un apoyo semanal por vía de la telemedicina. El proyecto ECO es, las siglas es Extension for Community Healthcare Outcomes. En realidad, entonces ustedes ven que es un proyecto dedicado a la comunidad. La misión del proyecto es expandir la capacidad de proveer mejor asistencia para enfermedades frecuentes y complejas en áreas rurales y en lugares menos privilegiados, alejados de los centros asistenciales y donde están radicados los especialistas. Los objetivos iniciales del proyecto, 11 años atrás cuando empezó Sanjeev, eran tratar con eficiencia y seguridad a los pacientes de New México, pero rápidamente se dio cuenta que esto tenía potencial y se dedicó a desarrollar un modelo para tratar enfermedades complejas en áreas rurales y también en países emergentes. Los métodos son el aprendizaje basado en casos, o sea, en los pacientes, compartir buenas prácticas en atención médica, el uso de la tecnología apropiada, que por suerte es cada vez más simple, y la existencia de una base de datos que permitiera monitorizar los resultados. Las etapas entonces iniciales fueron el entrenamiento de los médicos y el equipo de salud, iniciar un comanejo entre ese equipo de salud radicado en el interior y los profesores de la Universidad de New México radicados en la capital, de manera tal de crear un circuito de aprendizaje, como llamamos nosotros, un círculo virtuoso de enseñanza-aprendizaje que permitiera que cada uno aprendiera del otro y que todos se pudieran enriquecer entre ellos. Luego se creó o se buscó la recolección de datos y el monitoreo central de los resultados. La etapa siguiente fue la evaluación de los costos y la eficiencia del programa, y una etapa muy importante que está en pleno desarrollo en este momento, que es la ampliación a nuevas patologías y a nuevas áreas geográficas. Este proyecto ECO, que al principio se hizo para hepatitis C, tuvo rápidos beneficios para los médicos radicados en el interior y en áreas periféricas, ya que provee educación médica continua y gratuita. En Estados Unidos especialmente es muy cara la educación médica continua. permite la interacción con colegas que tienen intereses similares, combinan al mismo tiempo aprendizaje y trabajo, lo cual para una profesión del área médica es fundamental, y permite a los médicos de familia, médicos generales radicados en áreas distantes, el acceso a consultas especializadas. Ustedes ven aquí cómo es un día de trabajo, lo ven en el medio del salón al doctor Sanjivalora, está comunicándose por teleconferencia. Aquí ven con 7 u 8 centros, cada uno de ellos o alguno de ellos van a presentar un caso, brevemente un problema. Los profesores no ven al paciente, sino que se comunican con los centros. Cada centro que desee o que tenga un problema para plantear lo va a hacer en el tiempo limitado de 1 o 2 horas. Cada uno puede preguntar, opinar o interactuar entre ellos. Y ahí está entonces ese círculo virtuoso de enseñanza-aprendizaje, ya que todos pueden preguntar, los profesores van a aprender de cada uno de los que presentan y cada uno de los que presentan van a aprender entre sí. En realidad, acá todos son profesores y todos somos alumnos. Aquí ven, visto del otro ángulo, cómo hay allí 8 centros conectados, y en la pantalla en la otra pantalla pueden ver que de acuerdo a los problemas que ya saben que se van a plantear, se pueden hacer breves actualizaciones, pero no son grandes conferencias, no son conferencias magistrales, son actualizaciones de 10-15 minutos sobre algunos puntos que se plantean con los pacientes y que deben ser aclarados. Con esto se busca que el paciente quede en su lugar, quede donde él viva, que no se movilice de su pueblo, de su ciudad, de su área rural, que no tenga que movilizar a su familia, que no tenga que gastar dinero y que no tenga que hacer una larga espera para ver al profesional. También hay beneficios para el sistema de la salud, como una mayor calidad y seguridad, un aprendizaje rápido y una diseminación del concepto de buena práctica. Hay reducción en las variaciones en la atención, hay una reducción en las disparidades en el acceso de pacientes desprotegidos a la asistencia porque viven en áreas rurales, y además hay un buen entrenamiento del personal de la salud, y esto produce un efecto multiplicador, porque en una reunión que nosotros llamamos clínica eco, uno le enseña a 5, 5 le enseñan a 10, 10 le enseñan a 100, y ese efecto multiplicador hace que eco sea eficiente, rápidamente y con muy bajos costos. Otros beneficios para el sistema de la salud son la mejoría en la satisfacción del profesional, una relación costo-eficiencia positiva, menores traslados, menores costos para enfermedades más graves, y algo muy importante que lo veíamos específicamente ayer en la práctica en San José, una buena integración del sistema público y privado. ¿Cómo se seleccionan las enfermedades que pueden participar del proyecto ECO? Tienen que ser enfermedades frecuentes, con un manejo complejo, con un alto impacto en la sociedad, pero que existan tratamientos disponibles y en evolución, y que al existir estos tratamientos mejoren al ser tratadas. Acá ven algunos de los muchísimos ejemplos que hay. En este momento, el profesor Sanjivalora pasó en 11 años de tratar una enfermedad a tener una lista de más de 26 enfermedades, entre las cuales algunas están en este slide. El estado actual de la situación es que ECO se ha aplicado en 33 universidades de Estados Unidos, como en Chicago, Harvard, Washington, en el sistema de veteranos, el sistema más amplio, y se aplica a pacientes que consultan en más de 1000 clínicas a lo largo del país. También se aplica en Irlanda del Norte, tierra de nuestro visitante, en la India, en Canadá, y orgullosamente decimos Uruguay es el primer país en América Latina en aplicar el sistema ECO. ¿Qué hacemos en Uruguay? Empezamos en el 2011 muy tímidamente a convencer a la gente de que el proyecto ECO era aplicable en Uruguay. El primero, por supuesto, fue el decano de la Facultad de Medicina, que entendió, el profesor Tomasina, rápidamente, y fue un eficaz y entusiasta apoyo para nosotros. Se firmó un convenio con la Universidad de New México y la Universidad de la República. Eso fue clave. A partir de ahí empezamos a recibir material en forma gratuita de la Universidad de New México de gran valor para nosotros. En 4 años de trabajo se conformó un equipo interinstitucional e interdisciplinario integrado y apoyado por el órgano rector, como debe ser el Ministerio de Salud Pública, los órganos efectores como ACE y FEMI en lo público y en lo privado, apoyado por el Fondo Nacional de Recursos, clave para aplicar algunos tratamientos en nuestro país, el Sindicato Médico, la Academia Nacional de Medicina, últimamente se ha sumado el programa Salud UI y el Colegio Médico, y también, por supuesto, la Organización Mundial de Gastroenterología. Pero siempre desde un proyecto Facultad de Medicina, Universidad de la República, que es el orgullo, uno de los orgullos que tenemos, porque allí es donde deben nacer las iniciativas a nivel universitario público. El proyecto ha sido apoyado por la Embajada de Estados Unidos. La embajadora Reynoso tuvo la generosidad, primero, de traer a nosotros y segundo, de traer hace exactamente un año al profesor Arora a Montevideo, y ahora por el señor embajador del Reino Unido, que también generosamente apoyó la venida del profesor Watson. Mantenemos reuniones periódicas con todas las partes involucradas. Próximamente se instalará un consejo representativo, y desde el año pasado empezamos a trabajar en 2 patologías, que son hepatitis C y HIV, y a partir del 2015 sumamos 5 más: cuidados paliativos a cargo de la doctora Piris, anemias y problemas hematológicos frecuentes a cargo de la cátedra de hematología, la doctora Díaz, la doctora Guillermo y todo su equipo, prevención de cáncer cervical de la cátedra del profesor Brioso, en conjunto con el MD Anderson de Estados Unidos, el principal hospital de cáncer quizá del mundo. También tenemos un proyecto de insuficiencia cardíaca a cargo del profesor Pablo Rocha, y finalmente tenemos uno muy importante sobre autismo, que ya está trabajando con la Universidad de New México, donde sus integrantes viajaron el mes pasado a Albuquerque a formarse de la cátedra del profesor Jekyll. ¿Qué hacemos en Uruguay entonces? Recibimos la visita del doctor Arora, quien fue recibido entonces por todas las autoridades universitarias y de salud, por el presidente Mujica. Fue un momento clave, ¿verdad? Porque el presidente Mujica creyó en el proyecto y dio el visto bueno para que eso arrancara. Hemos enviado ya a 7 personas de nuestro equipo a formarse en Albuquerque, y empezamos una comunidad integrada de médicos y otros profesionales que en el momento actual están representados en casi todos los departamentos del país, y ya teníamos desde agosto del año pasado más de 60 médicos y personal de la salud trabajando desde, como ven acá, prácticamente todos los departamentos. Aquí ven la visita del doctor Arora con la embajadora, el señor decano de la Facultad de Medicina, la por entonces ministra de Salud Pública, y el doctor Arora con su jefa de replicación, la señora Hardy. Aquí recibió de parte de la Facultad de Medicina el doctor Arora, bien merecidamente por cierto, el título de profesor emérito, y de parte de la Academia Nacional de Medicina fue nombrado académico extranjero. Aquí ven un día de una jornada de trabajo de todo el equipo en la cátedra de gastroenterología del piso 4 de hospitales clínicas, que es donde tenemos nuestra base operativa. Ven que tenemos una pantalla casi tan grande como las que tenemos acá, donación de un amable paciente. Y allí ven el equipo de trabajo un día que estábamos reunidos trabajando en hepatitis C. Otro día acá ya ven que tenemos 4, 8, 12, 13 centros conectados al mismo tiempo, conversando y discutiendo pacientes con nosotros. Otra visión, un día que trabajamos en HIV, ¿verdad? Y aquí ven en la foto de arriba el equipo de nosotros de prevención de cáncer cervical del profesor Brioso, trabajando con el MD Anderson, la señora de campera gris o gris azulada. Siempre cuento esta anécdota que me resulta muy graciosa. Además de médica, es astronauta. Yo nunca había visto un astronauta hasta que vi una médica astronauta, que me encantó la anécdota. Y abajo el equipo de autismo también trabajando con mucho esfuerzo. Entonces, para terminar la exposición, en ultra resumen, ¿qué es el proyecto ECO? Es un sistema que quiere demonopolizar el conocimiento y democratizar el acceso a la atención médica. Profesor Watson, le agradecería mucho que nos ilustrara con su conferencia. Le vuelvo a agradecer enormemente el esfuerzo que ha hecho de ausentarse una semana entera de su país, de ir a trabajar como lo está haciendo de igual a igual, hasta tomando mate y comiendo dulce de leche con el equipo de la doctora Piris, y bueno, y las maravillosas conferencias y lecciones de vida que nos está dando. Gracias, profesor.
Buenas tardes. Thank you very much indeed for your very warm and kind welcome to Uruguay. Can you hear me all right? Is that a bit better? Sorry. It has been a fantastic opportunity to see Uruguay and to be kissed by many, many people and to enjoy the benefits of seeing a palliative care teams in Montevideo and also in San Jose, as they do great work. I was asked to talk tonight about difficult pain. Yeah, great. So I wasn't sure whether it would be best to talk more to doctors or more to people experiencing pain. So I pitched it kind of halfway in between. I hope that is okay. I wanted at the start to say a big thank you. Thank you to Dr. Cohen for arranging the invitation and for his enthusiasm for ECHO, which will make a huge difference, not only in Uruguay, but across South America, and I hope also in Europe and across the world. So I have to say thank you to the ECHO team and to Ms. Martinez for all her work too in bringing me here. I need to say thank you as well to the British Embassy. We have the consul with us today, and they have been super in arranging things and being so kind to us. And thank you to you for giving up a night to be here, to share and to learn together. I hope it will be useful for us. So what I'm going to do over the next 40 minutes or so is talk a little bit about pain and difficult pain and how do we manage it, thinking particularly from the palliative care point of view. So I'm going to go through some definitions about what pain is. I'm going to think a little bit about some of the key concepts which are really important when we think about pain and trying to understand how best then to treat it. So there's some key concepts to think about, and then a few things which I have found helpful as I've been trying to look after patients dealing with difficult pain. That's what I'd like to do. Okay. So in terms then of what is pain, I'd like to begin by saying how good pain and how important pain is, which may sound strange. This gentleman here is a guy called Raj Kumar. He comes from Nepal. He lived in a little hut just outside the hospital where I worked in Tansen, about 300 miles west of Kathmandu. And Raj has got leprosy. And because of leprosy, he was kicked out of his village and he lived outside the hospital. And the problem with leprosy is it stops people from feeling pain. And because he didn't feel pain, he continually was getting ulcers on his feet. He would show off sometimes to the children about how he could put his hand in the fire, which was disastrous for his hand. Pain is meant to protect us. If you do not have access to pain, you will have many problems. Descartes, in the 15th century, said this: pain evolved as a protective response to alert us to danger. So that's the good side of pain. Let's get on with the other side. Pain can be described as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. What do we mean here? Pain is always experienced not in our fingertips, it's experienced in our brains. And if our brains are diverted into other matters, then our pain will be modulated. I can say to you that last night, the people who were watching the football, I know Danubio were kicked out last night. I suspect maybe that the very fervent Danubio supporters, their pain tolerance was a little bit less last night. Yeah. They were not emotionally encouraged, especially in the last minute when San Paulo scored their second goal. So all the time, pain is being modulated by our experience. If we're really focused, we don't feel so much pain. If we're tired, if we're feeling sad, then maybe we would experience more pain. Pain, I like this definition. Pain is what the patient says it is. Pain is what the patient says it is. I have seen doctors arguing with patients and telling them, no, that doesn't hurt. What is the point? Pain is what the patient says. It's like a British person going to Buenos Aires and talking about the Falkland Islands and saying, oh, you don't need to be upset about that. People are upset because they are upset. You don't argue with them. Pain is what the patient says it is. How many people have pain? Lots of people with cancer have pain. We estimate that over the course of the cancer disease, maybe 75 to 80% of people will have pain. But it's important to know that 25% will not have pain, because many people think that cancer is always associated with pain, but often it isn't. But one of the sneaky things about pain is that often people will not just have one pain, but 2 pains or 3 pains. And so it's really important to assess the nature of the pain, to make sure that our treatments are specific for the different sorts of pain that people have. The first really important concept that I learned and was really helpful to me was understanding the difference between acute pain and chronic pain, because the two are completely distinct, very different. Acute pain is usually due to a specific cause which you know about, like a heart attack or a kick, a specific cause. It's usually of short duration, and because you know what has caused it, normally you can get treatment which works well. Chronic pain is much more difficult. Often the cause is unknown or has been forgotten about over time. It persists longer than 3 months, and treatment is really difficult because we have learned that pain changes our neurology. Pain changes our brains. And as our brains change and are molded by the pain, then it becomes much more difficult to break the cycle of pain. So chronic pain is much more difficult to manage. What is acute pain? It's a physiological response to tissue damage. It warns us that we're in danger of more damage. It helps focus where the pain is. It's got real value to us because it stops us from hurting ourselves more. And it responds to the traditional medical model. I'm sore, I take a tablet, I feel better. Or in the same way, when you were a little child and you fell over and you were crying and you went to your mother and she kissed it better, instantly it was better. How did that work? But it worked, it did. And life normally by acute pain is only disrupted by a short period. We talk about the fight, flight, and fright response because acute pain is associated with your autonomic nervous system going into top gear so that you can run fast away from the tiger which is coming to get you. That is acute pain. There's lots of value in acute pain. And here is how it works. The nerves are in your hand. They pick up the sensation. They send the signals along the nerves into your spinal cord and then up through your spine to your brain where it's all modulated, and then the brain may send down signals down to your spinal cord to either dampen down the signal or to increase the signal. And that's where our medicines work at all those different points. Chronic pain is very different, lasting a long time. It's pain that persists when it should have stopped. It's the continuing on of the process which should have stopped. It's really hard to treat. It gets associated with the person's emotions, and if it goes on long enough, we can say that pain becomes the disease. That pain itself becomes the disease. No longer a symptom. This person is a pain-filled person. It will affect every aspect of their life. It will affect what they eat. It will affect their relationships. It will affect their weight. It will affect all the things that they enjoy. It has become a disease. It's got no biological value. And the worrying thing is that as I look out amongst you, I can see nobody in this room who has got acute pain. There's nobody obviously in pain, but there could be many people in this room with chronic pain, and none of us would know. Because chronic pain is experienced in isolation. We don't have the fight, fright, flight autonomic expression of pain, and so nobody feels sorry for us. Or they say, it's all in the mind. Yeah, and that doesn't help much either. So chronic pain affects every aspect of our lives. It affects the quality of our life, our ability to perform our activities of daily living. It has social consequences. It affects our relationships with our sexual partner. It has psychological effects. It causes depression. It reduces our self-esteem. And it affects our ability to earn a salary. So chronic pain is a significant disease. When I was taught in medical school in Edinburgh, we were taught that the nervous system is laid down, and after it's laid down, it doesn't change. We now know that that just isn't so. We now know that new nerves can be created, that new pathways can be developed, and we know that pain creates these circuits within the brain system. And as I say, pain can become a disease. This was a quote from a patient with long years of chronic pain. They said, the pain doesn't go away, you just make room for it. You just make room for it. I had it described to me like this. Having chronic pain long term is like waking up one morning and walking out into the garden and suddenly you fall into a big hole. You get out of the hole. The next morning, get up, breakfast, go out, fall into the hole. Gradually, over time, you begin to work out where the hole is, and you learn to walk around it. Yeah? The hole doesn't go away, but you learn to live with it. So the next big concept are our two main classifications of pain. Nerve pain and what we call nociceptive pain, or ordinary body pain. What do I mean? Nociceptive pain is pains like mechanical pain, sports pain, arthritis pain. Neuropathic pain is pain associated with nerve damage. Let's have a look. So we've got these two classifications. Ordinary pain, which affects your bones, your joints, your muscles, or your organs like your heart, or your liver, your pancreas, etc. And then neuropathic pain, which again is very different. What am I talking about? Nociceptive pain is pain which is transmitted by a healthy nervous system. The wiring is intact. It works well. And an intact nervous system responds really well to morphine. It normally works really well to control pain. And so that's why heart attack pain responds usually really well to morphine type drugs. Neuropathic pain, however, is really difficult. It's pain associated with a damaged nervous system. How do you diagnose it? How do you know that you've got it? It's pain associated with tingling, pain associated with numbness, pain associated with some other kind of sensation, altered sensation. Pain plus altered sensation is neuropathic, and it's caused by a damaged nervous system. Why is that significant? It's significant because damaged nervous systems don't respond as well to traditional painkillers. Morphine can help a little bit, but it's likely that you'll get all the side effects of the morphine before you get on top of controlling that pain. You need to use other drugs as well, and the sort of drugs that we use are antidepressant drugs, which feed back down the spinal cord to dampen down the signal, or antiepileptics, which prevent the transmission of impulses. 3 different sorts of neuropathic pain. Central within your brain. So some people who have had strokes may get awful nerve pain because part of their brain has been damaged. You can get peripheral nerve pain. And we know people with diabetes where the circulation has been damaged to the small nerves, and they can get awful burning and tingling type of pain. Or people who have had surgery, maybe remove their arm, but they're still feeling the pain in their fingers, even though their fingers aren't there. The phantom pain that we talk about. Yeah? And the last sort of pain is sympathetic pain. The nerves which travel with the sympathetic system, which travel also with the blood vessels. And sometimes we can get nerve pain which is really difficult, which follows the distribution of the blood vessels. Okay, so this is the picture of nerves and the interaction between the nerve synapses and all the impulses, the stuff that is happening at the cellular level. Next concept, really useful concept, most of you will be aware of it, who are medical at all, is the WHO pain ladder. A really simple idea created by a guy from Sweden, and by following the WHO pain ladder, using very cheap medicines, it's possible to control as much as 80% of pain. What is the secret of it? It's the secret of it is starting methodically and using medicines in a systematic way. Not just saying, oh, I've got pain, let's try some tramadol, or let's try some oxycodone, or let's try... It's okay, we'll start at the very beginning. We'll start with some paracetamol. Does the paracetamol work? Does it not work? We add in some second line medicines. Does that work? Does that not work? If that doesn't work, we add in some more meds. And we build it up gradually and steadily until we get a combination of drugs which is working well to manage the patient's pain as best as possible. But the big thing to remember whenever we're prescribing analgesics is breakthrough pain. Can I tell you my experience? I came back from Nepal, and about a few months after I came back from Nepal, I developed appendicitis. Now, appendicitis for a woman is one thing, but appendicitis for a man is very, very severe. Because as you know, man pain is much worse than woman pain. So I had my appendix done, and the surgeon, he wrote in the operating room, he said, morphine, 10 milligrams, 4 hourly PRN. And I was sent back to the ward. 10 minutes after I got back to the ward, I began to feel sore. At 11 minutes, I called the nurse. Nurse, I'm sore. What did she say? She said, you have got 3 hours and 49 minutes to wait before you will get more medicine. 3 hours and 49 minutes of man pain. Never forget to prescribe breakthrough pain, so that if man pain breaks out, there's something that they can take. How much do you give? You give the equivalence of a 4-hourly dose. So if the total dose of the 24 hours is 36 milligrams, then you would divide that by 6, because 6 is a quarter. That's 4 into 24 plus 6 will give you a dose of 6 milligrams for breakthrough. Be kind, nurses. Be kind, doctors. Look after your men and women. The WHO is also based on some very clear instructions. It says that it's easiest if medicine is prescribed by the mouth, because that route is the easiest and the patients can take it very well. I think in France, people like taking suppositories, but here in Uruguay, we don't do that. By the clock. Don't give patients analgesia just to take whenever you're feeling sore. Why not? Because what happens is the pain builds up, and then they take the analgesia, then it goes away. And then they're left wondering, when is this pain going to come back again? It's kind of torture, because you're leaving people wait for the pain to come back. And so we work out what somebody's dose of medicine is, and we give it throughout the 24 hours to prevent the pain from breaking through. By the mouth, by the clock, by the ladder, as we've talked about, moving up and down the ladder. And lastly, and very importantly, we prescribe not for people, we prescribe for individuals, what they need, what they want. In Nepal, there were some patients who preferred to have their teeth extracted without local anesthetic. That was their choice. They didn't like the sensation of the local anesthetic. I thought they were mad, but that was their choice. So we have got to work around the individuals. This is Dame Cicely Saunders, and this is my belly, right there, just behind her. I got the shot. It's a very nice belly, and this was she was in her last 5 years of life working at St. Christopher's Hospice, and she is kind of like one of your country's national heroes in relation to palliative care. But she came up with a really important concept. She went round patients, and the patients that she was speaking to were patients with cancer. And in the 1960s, patients with cancer, they were kind of ignored. And when she spoke to them, she found out that they were feeling depressed, they felt abandoned, they were often in pain because they had been ignored, or the doctors and the nurses would just walk past them. And she realized that their pain was not just physical pain, it was emotional pain, it was social pain, they were isolated, it was spiritual pain. They felt abandoned by God, they felt they weren't who they were meant to be. And she realized that pain is a combination of all these things. There's the tissue damage, yes. There's the sensation of pain. There's the thoughts associated with that pain. There's the emotions which come from that. And then there's the suffering related to that. It's like pain is like an onion, and there are different things which will affect that pain. many, many years, Plato, he wrote this. I thought it was really helpful. He said, the greatest mistake in the treatment of disease is that there are physicians for the body and physicians for the soul or the mind, although the two cannot be separated. We cannot split people up into components and say, we're just going to deal with the physical pain. It doesn't work like that, because physical pain will always have a psychological effect, and vice versa. And so pain also has these components. And you've seen that with patients. I saw it a lot in patients in Nepal. Patients who came in whose main pain was poverty. They had no money for their children. They had got no money for medicines for their children. And they were in pain. Where was their pain? Did they need morphine? No. They needed a little bit of money to be able to look after their own children. Do you understand the point of I'm saying? I'm going to talk a little bit about some very complex pain. Why am I talking about this? Because we now know from PET scans and functional MRI scans that what I'm talking about is actually real. That when you experience emotional pain, when you experience social pain, the parts of your brain which light up are the same parts of the brain which light up when your hand is damaged in a fire, when your tummy is full of cancer. It's the same part of the brain which is letting you suffer. Isn't that interesting? It's the same part. So we're dealing with something which the body interprets as pain, the mind interprets as pain. I'm going to talk about complex pain. You may have heard of this event. It was in the World Cup. It was in the last match of the group stages, and Giorgio Chiellini had just been bitten on his arm. It wasn't a very deep bite, but for him it was awful, because there was a lot of psychological benefit for him to have his arm hanging off. Yes, there was a lot of things making that pain really, really bad. And then there was a footballer, maybe you've heard of him. He is called Luis Suarez. And he had bitten this gentleman. And he was now in awful pain. Oh, my teeth. Because he realized what an awful thing he had done. And his pain was huge. And then there were the people back in Uruguay watching the television. Oh no. The pain across the whole, what has he done? Our Louis, what has he done? And the pain was really difficult. Yes? This is complex pain. Was the pain real? Absolutely. Was the pain due to the amount of tissue damage in the Italian's arm? I suspect not. But what made that pain so bad were all the social, financial, emotional, cultural, national implications. And I can tell you that that night in Montevideo, the people who have chronic pain, their pain got worse. They had more pain. Why am I saying this? I'm saying this because we do not treat a static thing whenever we treat pain. Pain is constantly changing. Constantly changing. on the day that Uruguay beat England in the World Cup. There was no pain in Montevideo at all. Yeah, because people felt good. Do you understand? So total pain, yes, it needs good drugs. Yes, it needs the nerves to be treated. But it also needs understanding of all the background that creates that pain. Okay, I'm moving on to just 5 things connected with what I think is really helpful in managing pain. And the biggest, most important is assessment. Making sure that when you assess patients with pain, you do that as well as possible. And it takes a little bit of time, and it needs you to listen. To listen. When I was a junior doctor, I knew how to treat pain. The nurse would say, "Doctor, patient number 3 is in pain." Aha, no problem. 2 paracetamol, 4 hourly, PRN. Write it down. No problem. Pain treated. But I wasn't treating pain. I wasn't treating people. Rather, I was just treating pain. And I wasn't effective. So we need to assess. And we need to assess pain well. Some people say describing pain only in terms of its intensity, is it severe pain or little pain, is like describing music only in terms of its loudness. Pain has got many different aspects. And we've got to be particularly careful when we're assessing people with pain who are older. Because the older people, often they say, "Well, I'm getting older, I can expect to be in pain." And they don't complain as much. But maybe we could really help their pain. But they don't let us know. The cognitively impaired, those with dementia, people whose first language is not Spanish, they can be really difficult to understand. And those of your patients who abuse opiates, the heroin addicts, they can be really difficult to treat. Are they asking you for pain medicine because they want another fix, or because they really are in pain? Really difficult. And patients at the end of their lives, it can be difficult to assess them. I'm going to mention the football side of things. No, we're not going to. Okay, assessment. Okay, so making sure that we assess properly is really important. There are lots of different schemes for assessing, and it's important, if you're a doctor or a nurse, that you use such a scheme. You need to know when the pain began, where it goes, what makes it better, what makes it worse. Do tablets help? Do they not help? Does food help? Does it not help? Those sorts of questions, but asked in a methodical, clear way, so you've got a clear understanding of the pain. And once you've finished getting that understanding of the pain, you need to ask about the next pain. Because often there'll be a second. And the average number of pains that somebody with cancer has is 3. 3 different pains. And working out what they are so that you can treat them as well as possible. Next big thing, which I think is really helpful if you're looking after people in pain, is setting expectations. Setting expectations. What do I mean here? I mean, this is an advert for some form of pain medication. It says, "Live pain-free." If you set your expectations for the patient that you are going to get rid of all their pain, you are going to fail as a doctor. And so, with my patients, I normally would say, "Look, your pain is really difficult. What I hope we might be able to do is reduce your pain maybe by 50%. That's what I'd hope. And then, if you get it down by 60% or 70%, aren't you the fantastic doctor? But you've set the expectations real. It is a false expectation to expect that we will be able to remove all pain, and we set ourselves up to fail if we do so. It's a false expectation. Number 3. When I started in palliative care, we were told that morphine was always safe for palliative care patients because the pain would soak up the morphine, they wouldn't get side effects. It was all just a case of making sure that the patients got enough medicine to control their pain. But we now know that there are problems, particularly when palliative care doctors look after patients with chronic pain. Palliative care doctors are toxic to patients with chronic pain because we give out too much medicine and we cause problems that way. We've got to be really careful about treating chronic pain. In patients who are approaching the end of life, really important that we prescribe according to their absolute needs. But the long-term effects of morphine are huge. We know they damage the immune system, that they have caused more deaths in the United States than illegal drugs because they have been used without care. And the awful thing is that only 30% of patients with chronic pain actually get benefit from it. And 20% of people prescribed morphine for chronic pain will develop addiction problems. I've got to be very careful here, really clear. I'm not talking about palliative care patients in the last weeks and months of life. I'm talking about patients who have got long-term pain problems, being given morphine indiscriminately. Number 4, the importance of making sure that when we prescribe for pain, we do so in a particular way. This is my new guru, Atul Gawande, an endocrine surgeon in Harvard, who writes really well about looking after people in pain and looking after people at the end of life, and how important it is to make sure that people know or are able to express what their opinion actually is. People need a specific strategy for managing their pain. I know a man who has got awful long-term pain due to a damaged vertebra in a road traffic accident. But he chooses to remain in pain rather than have the side effects from the drugs. I know of other people who would prefer the side effects from the drugs to the pain. We need to find out from the individual what they're prepared to put up with, what they're not prepared to put up with, and to work with them in devising a plan for them to manage their pain in the best way that they can. Individualized care. The pain treatment continuum begins from the least invasive side to the most invasive side. And we begin with the psychological approaches which encourage people to talk about their pain, to express their issues, and to get the diversion. I know we have done something with our patients in the hospice using music that we've found that if we put on headphones on a patient whenever we're doing dressings, that they don't need as much analgesia. We'd like to do an experiment with virtual reality so that we could put goggles on the patient and they could go and walk on the Rambala and have that experience of the seaside, because we think that would reduce their need for painkilling medicines. Then we talk about topical medicines, causing less interaction, the rubs, some of the gels that we use, and then the specific tablets that we talk about, beginning with the less sedating medicines, the non-opioids, and then the opioids, and then lastly, when we go to our anesthetic colleagues or to our surgical colleagues who will do procedures to cut nerves. So we have a lot of things that we can do for difficult pain, but the most important is to develop a relationship with the patient so that we can work out what is important to them. And these are all the different drugs that there are and where they work in the nerve pathways. Harvey Cushing was one of the founders of modern medicine, and this is a very important phrase which he said. A physician is obliged to consider more than a diseased organ, more even than the whole man. He must view the man in his world. And if we're going to manage disease, we have got to do that. Pain that is acceptable to one person may not be acceptable to another.
Pour une banque, il est essentiel de comprendre les différences de point de vue.
Understand? What is acceptable to what is not acceptable. So, our role then in difficult pain is not just to fight the pain, it's also to make the person stronger to cope with the pain. And we do that in teams. We use different people, different skills to help build up individuals so that they're stronger for dealing with pain. We have a plan in our hospice to train children to build up their capacity to deal with tough stuff. Because we're seeing so many young children, young families coming into the hospice, and they're devastated because they haven't learned to deal with any problems in life. And so they've got no resilience. And so much of the West has been infected by the American idea of, everyone's a winner, but everyone's not a winner. We've got to learn to deal with life. It's tough bits and it's not so tough bits. So we need, yes, the help of nerve blocks, the help of nursing care, physical medicine, physiotherapy, occupational therapy, all the ways that we can help to build resilience, to give people that strength for dealing with pain. A team approach is really important, and here is where ECHO has been really useful. This is when we connect with nurses who are looking after patients with difficult pain, and because they can connect in to the central ECHO team, then they can get advice from our pharmacist, from our doctor, from our psychologist, to get all the different approaches to help them as they manage a difficult patient. How ECHO can really work in managing difficult pain by working together. It's a great way forward. Because it takes a team to manage pain. It takes a team to really manage pain. No individual on their own can manage pain. We need to work together. So you've got this demonstrating what are we doing? We're building resilience. An example of resilience. Yes? And we've got to expect that our patients can have resilience. Sometimes we are so proud of our abilities as doctors that we can disempower patients because we don't trust that they can look after themselves with just a little bit of help and support. We've got to believe, yes, you can deal with this. Yes, this pain must be absolutely awful, but I believe that you can deal with this with a little bit of help. Rather than, oh, you need to come back and see me in 2 weeks' time, and in another 2 weeks' time. Building dependence. We've got to make the patient take control of their life. So that's what we've done tonight. We've looked at some definitions, some key concepts, and some ideas about managing difficult pain. I want to leave you with one last message, that if you're involved with helping somebody with pain, or maybe you have pain, what I would encourage you to do is always think through the implications of your treatment. Make sure that your treatment helps your pain and doesn't make your pain ultimately worse. But he can't swim. You understand the point. Thank you very much indeed.
Muchas gracias, profesor, por la maravillosa conferencia. Mientras van pensando en alguna pregunta, quiero decirle algunas cosas. Primero que les agradecería si se quedara un ratito, vamos a tomar algo al finalizar la charla para brindar por el profesor Watson, por su generosidad y por el futuro, esperemos, exitoso del proyecto ECO. Segundo, que si alguno se quedó con ganas, mañana va a ser la última conferencia del profesor Watson al mediodía en punto en el NH Columbia. Y tercero, mientras ya creo que ya veo alguna cara con ganas de preguntar, quiero decir que el trabajo inconmensurable que significó esta semana no es solo del equipo médico y del equipo de salud propiamente dicho. Tenemos 3 personas que son maravillosas: Carlos Reolón, que está aquí, Carla Muñoz, que está por allí, y el verdadero motor de este equipo, que aprovecho ahora que se fue porque si no se fue muy colorada, que es Elisa Martínez. Es una locomotora, sin ella en todos estos meses no hubiéramos podido hacer nada, y pido para ellos un fuerte aplauso. Some questions, would you be happy to take some questions? Sí, adelante.
Me gustaría saber el rol de la terapia ocupacional en el manejo del dolor, porque no es la primera vez que lo nombra, lo ha nombrado también en alguna charla un poco más en el equipo, en el Maciel, y me gustaría saber el rol que cumple en el manejo del dolor.
Thank you very much. It's really something that we use a lot in Ireland because people's work and people's daily activities contribute a lot to their pain. If you get pain whenever you're having a bath, then you maybe will stop having a bath. But if there can be a handle put above your bath which allows you to get into the bath without triggering your pain, then maybe you don't need to take your morphine that morning, which means you're not for the whole day. So occupational health is all about trying to make your activities of daily living as pain-free as possible without using medicine. And there are devices to put on your shoes or to eat, which will allow people, say, with very bad rheumatoid arthritis, whose hands are sore, to eat without pain. And so that is what I mean by occupational health advice. Does that make sense?
¿Alguna otra pregunta? Doctora Piris, está bárbaro, a ver, te parece que te conozcan porque sos la gran especialista en este país de este tema y la líder de todo el grupo que nos trabaja. Te pusiste colorado, no importa, va por cuenta mía.
Profesor, usted nos habló muy bien de los efectos secundarios que puede haber en el dolor crónico cuando sobredosificamos a los pacientes. ¿Cuáles son los efectos secundarios que ustedes ven con el uso de la morfina en el paciente con cáncer en cuidados paliativos? Los efectos más frecuentes.
As I'm sure you know, the side effects that we really worry about are the side effects associated with drowsiness, with hallucinations, with constipation, with nausea. Those are the common ones that we see, and people who develop delusions and delirium will become quite agitated. And very occasionally, morphine can have a very strange effect, and it can actually sometimes make pain worse, and you get what they call hyperalgesia. Fortunately, it only happens in a few patients, but sometimes the morphine can trigger the nerves so that they become extra sensitive to pain stimuli. And in that circumstance, what we need to do is reduce the morphine, which sounds strange, but that will actually often help the pain. So the big ones are confusion, delirium and agitation, sleepiness, nausea, and constipation. And of course, in the acute setting, if people suddenly get a big dose of morphine, then their respirations may decrease. But hopefully, in the way that we use our medicines, that doesn't happen. Morphine is a really safe drug to use if the person who's using it is safe.
Bueno, dijimos que íbamos a terminar 8:30, son las 8:30, así que vamos a terminar. Me queda solamente volver a agradecerle a todos ustedes, a la doctora Bott, que ha hecho la interpretación, así como los días pasados la doctora Inés Praval, a las autoridades de Antel, que generosamente nos han cedido la sala, el personal de Antel que eficientemente nos han colaborado, y vuelvo a agradecer, a pesar de que no están aquí presentes, a las autoridades de la Embajada Británica en Uruguay, que fueron fundamentales para que nos pudiéramos enriquecer en esta semana con la presencia del profesor Watson. Profesor Watson, muchísimas gracias. Bueno, vamos a tomar algo aquí a costado.